for Marshfield Clinic Health System, Jim Jones, Medicaid Director for the Department of Health Services, Representative Amy Loudenbeck, John Nygren, Executive Director for the Wisconsin Association of Health Plans, and Dr. John Schneider, Chief Medical Officer for the Milwaukee County Behavioral Health Division. Thank you all so much for sharing some of your valuable time with us today. Before we get started, I want to make sure we also thank Badger Bay Management for hosting today's virtual event in partnership with Wisconsin Health News. And thanks so much to our generous sponsors of the Wisconsin Health News panel series. These important and valuable discussions truly would not be possible without their support. So a huge thank you to AARP Wisconsin, Ascension Wisconsin, Advocate Aurora Health, Group Health Cooperative of South Central Wisconsin, Hush Blackwell, Marshfield Clinic Health System, Wisconsin Medical Society, and WPS Health Insurance. Wisconsin Health News is a nonpartisan, independent online news service. In addition to hosting events like these, we also publish a daily email newsletter. If you're not yet a subscriber, I encourage you to sign up for a free trial. You can do so by signing up through the event evaluation, which we'll email out after today's event, or you can also sign up on our website at wisconsinhealthnews.com. And an extra thanks today to Hush Blackwell, today's featured sponsor. We are very grateful for all of their longstanding support. And here to say a few words from Hush Blackwell is Robin Leniger.
Good afternoon, everyone, and thank you, Tim and Wisconsin Health News, for putting together yet another great slate of speakers for us today. Our firm has been a proud sponsor of the Wisconsin Health News since its inception, and we're continually impressed by the excellent, timely content that hits our inboxes every day and the compelling discussions that Tim facilitates throughout the year. That's become even more apparent over the last 18 months while we've battled the COVID-19 pandemic. I'm looking forward to hearing from today's panel on the future of telehealth here in Wisconsin. Hush Blackwell is an AmLaw 100 firm with a national reputation for providing exceptional healthcare legal services. Our industry-first approach brings together legal professionals across specialties with a breadth of experience, particularly in the healthcare industry, to meet those clients' needs. Our healthcare industry team includes more than 150 skilled attorneys nationwide, with about 20 of those individuals practicing out of our Madison and Milwaukee offices here in Wisconsin, all of whom have a deep understanding of the rapidly changing healthcare regulatory environment. We serve providers across the entire healthcare ecosystem in areas such as regulatory matters, compliance considerations, corporate transactions, mergers and acquisitions, labor and employment, and 340B program compliance, just to name a few. Our team has a breadth of experience serving health systems, providers, healthcare technology companies, long-term care providers, and many more. We're privileged to serve healthcare providers across the state and throughout the Midwest, and any more information can be found on our website, which is hushblackwell.com. Thanks again, all of you, for your time. Looking forward to the presentation, and with that, I will turn it back over to Tim.
Thank you, Robin. Thanks so much for the kind words, and thanks again to Hush Blackwell for all of your really generous support. So today's event is focused on the future of telehealth in Wisconsin. Virtual care reached new heights during the COVID-19 crisis, leapfrogging years of development and boosting access for many. But while the technology broke down barriers in areas like behavioral health, patients returned to hospitals and clinics for other services. And with telehealth flexibilities tied to a temporary public health emergency, debate remains on how to cover and pay for the technology. So we're hoping to dive into all of this and more during today's discussion. We've got a great lineup of panelists to help us out. So I am going to try to get out of the way and turn it over to the speakers that you really logged in to hear from today. And so Jim Castellano, let's start with you. Marshfield has been an early and aggressive adapter of telehealth. During the Wisconsin Health News event last spring, during the early days of the COVID-19 pandemic, your CEO, Dr. Sue Turney, told us live from her grandson's bedroom that quote, the genie was out of the bottle when it came to the quick advancements made to telehealth in response to the growing crisis. A year and a half later, how true is that? I mean, how has the pandemic changed how telehealth is used at your system? And what are some of the changes that you've made that are going to outlast this crisis? And Jim, I think you're still muted.
Thank you, Tim. So yes, a lot has happened in the last 18 months in preparation for the pandemic, and some of the barriers that have been lifted, such as the ability to bill and charge for phone visits or telehealth at home. Telehealth at home is really connecting with the provider at home via iPad, any means of connecting video to video. So those barriers that were lifted have really accentuated our ability to increase access over this pandemic period. The lifting of the barriers of the MSA components as well, the metropolitan service area barriers, has also helped with the expansion of access during this period.
How has telehealth use varied across the system? I mean, I know that a lot of systems, telehealth use spiked in some specialties, but then went back down after an initial COVID bump. It stayed up in others. What's kind of been the overall experience at Marshfield?
Yeah, so prior to the pandemic, we were seeing with our traditional telehealth. Traditional telehealth, by definition, I'll explain, is where a provider is in one facility and the patient presents at a regional facility, and they are connected by video. And so prior to the pandemic, Marshfield Clinic was seeing just over 1,000 visits of traditional telehealth a month. With the introduction to phone and introduction to telehealth at home, our traditional visits dropped off. We are now back up to about 900 plus visits since then. Our phone has really been about 65% of our visits over the pandemic. And now we are about 50-50 with telehealth at home visits as well as phone visits. And like I said, our traditional telehealth continues to get back to those pre-pandemic numbers. In response to your question, what type of telehealth do we have out there? Well, we do have the traditional telehealth where we are connecting facility to facility. And we have our phone care, we have our telehealth at home. In each of our 9 ERs, we do have telestroke cart that is designated to treat and triage those stroke patients that are being presented at those regional facilities. We also have telepharmacy, where a PharmD is leveraged remotely to oversee the dispensing of medications in other pharmacies. We have a new initiative, telehospitalists, where we have 2 robots. We have one in Neillsville, MMC Neillsville, and we have one in MMC Ladysmith, where hospitalists can round and be available to some of these regional facilities via telehealth.
And what with these latest numbers that you shared, how has this latest COVID-19 surge impacted that? Are they reflected in that? Have you seen another spike, or is it kind of similar to what it was this summer?
Our telehealth numbers seem to follow the trend of those surges. Yeah, definitely.
Interesting. Well, thank you. We'll come back. Dr. Schneider, I want to move over to you now. In addition to serving as the Chief Medical Officer of the Milwaukee County Behavioral Health Division, you are a past president of the State Psychiatric Association. In what ways have changes in telehealth use over the past 18 months impacted behavioral health care? I mean, for example, what impact has it had on access?
We've been able to reach more individuals. In many cases, the issue with the facility requirement that it be facility to facility and reach people at home, we were able to pivot, particularly with Milwaukee County, a number of our home visits to, we could do them as telecalls, and you could get more patients seen on any given day. I think the big challenge with this is a methodology is sorting out which are the right ones to still see in person. I think that otherwise, on the therapy side, quite often it's better to get the evaluation of people in their home setting. You get a better granular feel for what's really going on as opposed to how they look in the office sometimes. I think in general, everybody has adapted and liked it, but I think there are some challenging problems if we continue this way related to reimbursement and everything else. I suspect we're going to get into as the day goes on. But in some ways, I think this was a unique opportunity for everybody really to just get down and dirty with the technology and see what it's capable of.
Great. Thank you, Dr. Schneider. And just to know, Dr. Schneider is he's in his county office today, and is the reason that he does not have video on. But Dr. Schneider, thank you. And yes, we will come back to payment and some of those other issues a little later on. in the program. John Nygren, let's go to you. How have the state health plans embraced telehealth? Is increased telehealth use something they generally support? If so, why?
Well, I would say that our members definitely have embraced the use of telehealth, in a lot of different ways. And I would also point out that one of the best things that have come out of the pandemic is the implementation of telehealth. But it's important to note that one of the key factors of that was there's actually kind of government getting out of the way. Less regulation allowed for innovation and to be able to develop these systems and put them in place that could be more effective for members throughout the state. So I think we have to be very careful as we move forward to make sure that we're still using clinical evidence and best practices to be able to make sure that we're not simply placing things into state statute that make it more difficult for innovation in the future to continue to take root in not only Wisconsin, but I'm sure this conversation is happening throughout the nation.
Excellent. Thank you, John. Jim Jones, in the beginning of the pandemic, the state Medicaid program acted swiftly, enacting a series of emergency rules to help providers respond to the COVID-19 crisis, completing a process that really normally takes months and really a matter of weeks and days. Can you just provide just a brief synopsis of what some of these bigger changes were and kind of where things stand now?
Sure. I don't know who had a crystal ball, but thank goodness the legislature and the governor enacted legislation that changed the telehealth landscape with Act 56 back in, I guess, November of 2019. So apparently they saw something coming none of us did. And we began our work on policy. We figured it's going to take us 6 to 9 months to put something in place. And then in March, all of a sudden, we're in the middle of a pandemic, and all of a sudden we need to make sure our members are getting services. So we did something we called Rip the Band-Aid Off. Basically what we said was any service that could be provided via telehealth and did not require an in-person interaction could be done using the telehealth policies that were out there. At the same time, we received not only flexibilities through the emergency administrative role, but we also received a number of flexibilities from the federal government. The Centers for Medicare and Medicaid Services jumped into the telehealth big time. Medicare changed its rules quickly. Medicaid said, tell us what flexibilities you need and we'll give you them. And all of a sudden we were doing a lot of telehealth services across the state. And we did this as a temporary policy, really kind of playing it by ear. And then we began the process of really putting a permanent policy in place. Basically, what's great about it is we've gotten the chance to really learn from what's occurred. We've had this basic year and a half to really determine what works best in telehealth for us and for our members and for our providers and plans. And we began a process using a lot of stakeholders to put that permanent policy in place. And so on January 1st of 2022, we'll put a permanent policy in place that'll look very much like what you see today, but with some additional pieces to it that I think people will welcome, including paying the originating site if it's a medical office or a pharmacy or whatever, to provide a place for people to do their telehealth business if they're a Medicaid member. So we're going to move in that direction. We are still working on the asynchronous part, which is the out of sync kind of thing where you take a picture of something, send it to your dentist, he comes back with a message. That's coming, but it's not coming right away. It's going to take us a little while longer. We have to have an administrative rule completely promulgated to get that in place. But otherwise, what you see right now is in many cases the same rule that you're going to see in the future with, I think, some improvements actually.
And then just to follow up on that, Jim, what are maybe some of the additional changes? You mentioned one, but are there some other kind of big changes, additions that might be part of this once it becomes permanent next year?
Well, pretty much. We're going to leave our reimbursement services the same for in-person and telehealth. We're going to make sure that audio only is still available as a telehealth option for everyone in the state. We've gotten assurances from the Office of Civil Rights at the Health and Human Services Department that we were going to be allowed to do that. We're talking about expanding teledentistry. We're also talking greatly about really looking close at the doc-to-doc consultation. We're allowing that now. We want to expand on that as much as we possibly can to make sure that we have the best medical advice for our members as possible and making sure that we see that coordination among healthcare professionals that's needed. And again, that last thing, the idea of providing a a payment to the originating site. Again, it has to be a Medicaid provider so far. We may expand that further once we see what the interest is in other sites. But the idea that you could go to your Walgreens, sit in a room, do your telehealth visit because you don't have good internet at home, or wherever you might go is kind of the direction that we're leaning right now. And that would be something we'd have in place for the first year.
Great, thanks, Jim. Representative Loudenbeck, you have been a strong supporter of telehealth, including authoring this bipartisan 2019 bill that Jim just referenced, which, among other things, requires Medicaid to cover telehealth the same as in-person visits. Why, and you've spearheaded and been involved in other proposals. I mean, why do you see such promise in telehealth?
Well, I think we've seen so many great examples, but when we were in the process of doing the bill, it was really interesting to sort of think outside the box and plant the seed of what telehealth could mean. And one of the areas that I think I talked about the most was in behavioral health, and just the challenges with the lack of specialists, with the population, particularly Medicaid. I remember visiting with my county, and I have Rock and Walworth counties, but talking about if youth could come there and access their services so they didn't have to travel to Madison and Milwaukee and worry about childcare and transportation and all the things that we have seen materialize. Those were the exciting things because we really wanted it to create opportunities for better access. At the time, I think I probably had more concerns about privacy and making sure that the quality of care was going to be equivalent. And so this test period that we're in has been, I think, really helpful and will inform the rulemaking. But it was interesting. I know what we did in Wisconsin was different than what other states did. Some states did a complete mandate across the board. We started with Medicaid and really worked with all of the stakeholders. And we are also working on a trailer bill now to kind of make sure that what we did inside of DHS, we do not want DSPIS to come in and try to reinvent the wheel. And we want it to be consistent and sort of if we only need one clearinghouse and rulemaking process, I think, for telehealth in Wisconsin, and it already exists. So it's sort of a preemptive measure, but by and large, I think
I'm sorry, this would be a bill that you're currently authoring that would define telehealth in state statute?
Yep, it actually just takes the same definition we used in the 2019 Act and puts it in the definition into DSPIS. So everyone is starting from the same place. So again, one of the other, and to follow up, final word to comment on your question, I think the other piece was the rural access. And I think that's what made it exciting for all of our members, was to have the opportunity to think, what if there's a snowstorm? I mean, just what if you don't have, like I said, the transportation, the issues that are barriers, I think, in rural areas, like specialists. So not just the Medicaid population, but I think the entire population, it will see advantages at so many levels.
Excellent. Well, thank you. So there seems to be pretty broad agreement amongst panelists in terms of kind of overall embracing this technology and the potential, at least in certain areas, of improving care and boosting access. But despite this progress, all this progress has been made in the last year and a half, barriers certainly remain. A big one is, of course, solid internet access, which is still far from a given in many parts of the state. Jim Castellano, this is especially true in rural Wisconsin. Just how widespread of an issue is broadband access? And Jim, I think you're still muted.
Excuse me.
You're supposed to be our virtual care specialist here.
I know I should be like Pavlov's dog here and get a response. Excuse me. So, it's spotty. The northeastern part of the state is still very sketchy with the broadband access. And I know Chris Meyer, the director of telehealth for the Marshfield Clinic, who I report to, who is not able to be on this panel today. But I know he's very active with the state in the expansion of that whole broadband component. So it is sketchy, and it is, that's why we were just so thankful that phone care and telehealth at home have really helped expand some of those regions that don't have that broadband internet service.
So can you talk, I guess, a little bit more, kind of expound on kind of what the state is doing to address this, and maybe, what more, what's not being done right now that can be done from a state or policymaker level?
I'm not really well versed on what those policies are at the point. Chris is pretty intimate with those. I do know that Chris is sitting on several panels on the governor panel, I believe, in the broadband initiatives that are being across the state, but I am not at this point well versed in to speak to those.
Okay, so I know that at the Marshfield level, Marshfield is working with Elon Musk to figure out how well low orbit satellites can boost internet access in rural Wisconsin. Can you just talk a little bit more about this kind of specific initiative at Marshfield?
Yeah, there was a specific dot on the map that they were targeting that was in our service area, and there is a series of satellites that they will put into orbit, and they have both a incoming and outgoing capability of connectivity, and they rotate at a very low level. I don't know exactly how high up or how low that these satellite systems, but it's a whole string of satellites that will move across the sky that will provide that access to those rural areas that do not have broadband access now. So yes, Chris is working with that team as well.
Representative Loudenbeck, broadband access does appear to be one of these issues that, at least overall, has gained bipartisan support. What more can legislators do to address broadband issues in the areas like the ones you represent, where some places it can still be an issue?
Well, I think we're in sort of the third, if not the fourth iteration of advancing broadband opportunities. And just let's just say this, whether it's Wi-Fi, wireless, or wired, or cable, or satellite, all of the different options that are out there. But, back when, I would probably say 2012, I'm just thinking back when we created the Office of Broadband, started working on the mapping, all of those other things. Well, now 10 years later, 8 years later, we're updating those maps. We need better data. I think we're going too much off of anecdotal evidence or census tracts, and I see some nodding heads. But to really try to key in on it, and I think that one of the things that we did right is we required these local partnerships with the providers, because I'd rather have a town clerk in one of my towns of 800 people, or a town supervisor, working with the provider. That's not something that I don't think legislators should pick and choose where these investments go. But we're also in I think that the public is aware that this discussion isn't just about the haves and have-nots. It's about how much, how expensive. There are all these other factors that are coming into consideration where people say, well, I can get broadband, but it's too expensive. Well, that's different than access. Or I can get access, but I need more bandwidth or more capacity. And so I think we saw just within the last couple of days, there was an article about that now that the new federal requirements are coming out, and they are more favoring rural, because they're creating the rule based on available access, but they also are setting the bar higher for what the end product is going to be. And so then the rural grants will have better quality than what they have in Milwaukee. And so it's kind of an endless, I think, battle between how much, where, and what we do. But regardless, I think we're continuing to have forward movement. And I really, really think what I come back to is that mapping and better data, so that we're making good decisions. I mean, the money piece, it seems like there is private investment, there's federal investment, and there's state investment that's significant. So hopefully that we'll continue to just see forward movement in that. And in the places that we don't, I was excited to hear Jim Jones talk about partnering with another provider, whether it's a pharmacy or a county community health center, or wherever it is, so people can have the opportunity. Again, like I said, with this privacy, it's I think that's an incredibly important issue for no matter what level of healthcare you are seeking, even if you're going to, we're going to talk about behavioral health or some substance use disorder, if you can go to a group meeting or something like that. I mean, you need to have a space that's appropriate.
Great, thank you. So Dr. Schneider, let's move on to you. As was brought up, broadband access is not just a rural issue. Having the internet is one thing, but a big part of access, is also having enough bandwidth to make a video call or having a smartphone to do it on your phone. Can you talk about some of the access issues faced in urban areas of Milwaukee and what more can be done to address this?
We still have issues related to technology gaps, that you may have broadband access, but you don't have an adequate device that can do state-of-the-art current data exchange. We also have individuals, particularly in the geriatric population, who, the number of psychiatrists who have told me they've had a meeting where one of the young kids has set up the system for the parent or the grandparent to have the meeting because they don't have the tech support to set it up themselves. So I think we need to look at more than just the pipes, as it were, but also the technology on the ends and how we make sure that's as equitable. There are lots of places in Milwaukee where even if there's broadband close by, it may not be at the right spot.
And I guess, can you just expound on that, Dr. Schneider? I mean, what more needs to be done to address this and ensure that this increase in telehealth is done in an equitable manner?
It's not clear to me what mapping has been done. When I think about some of the community health needs assessments the health systems do, I don't know if they've looked at teleaccess as part of that assessment they do to sort out where are the gaps. I would think there should be some sort of joint between either the providers of the teleservice and or the healthcare providers to say, where are the technology gaps so that we can come together to figure out what the options are to fix them.
So it's been mentioned a couple of times so far today, audio-only telephone visits as an alternative. Dr. Schneider, I know you've expressed support for reimbursement for this. How does this help? How does this improve access? And what are some of the limitations? Specialists in behavioral health, what are some of the limitations, if any, of this option?
So audio only has been around. There's lots of, if we look back even 15, 20 years, there's lots of people who started psychotherapy or analysis with someone and would move out of town and they would pay out of pocket to continue phone conversations. If we think back to the classic picture of Freud with someone on a couch, you can do it without necessarily having a direct view of the person. So audio only works, but it needs to be constrained for what it works for. There's lots of things where you do need to see the person, and there's things where physical exam is still important. So if you're evaluating people for substance use disorders and you're trying to sort out, do they have a tremor? Are they diaphoretic, things like that? You still need a live person in the room doing parts of that. So I think it's not that it's not adequate. The question is, now that we've broached all of this, and I like to pull the Band-Aid off, now the question is, which ones are the right ones for which, and not make it so that there's no innovation, but so that we have good matching of evidence-based treatments for what the methodologies out there are. I think it's going to continue to take a broad approach because not everything works for everybody, and it won't work in every area for quite a while yet.
So right now, a bill is going through the legislature that would, among other things, require Medicaid to cover and reimburse mental health therapy conducted through audio-only telephone. Jim, you mentioned earlier that this is something that the Medicaid program is already looking into. This could be part of these rules starting next year. Can you just expound a little more on that? I mean, why is this something that the Medicaid program thinks is important? Why, kind of what is some more details on the status of this?
Yeah, a couple of things. Number one, I think telehealth is awesome. I think that it works in a lot of situations incredibly well. I think it meets the needs of our members most of the time. As long as it's a member choice, I'm for it. But at the same time, we have to be careful about widening the digital divide and the digital divide resulting in any sort of racial or ethnic disparities in our outcomes. And we could see that. So one of the things is, well, we need broadband across the state. Well, that takes time. I was on the internal broadband group across the state. And one of the things I realized pretty quickly is it takes time to get those investments made, get those systems set up, make sure that there's access to everybody else. And for a lot of our members, it's not sometimes not even a question of broadband. In some cases, it's a question of what's the device that I have, or what data plan am I on, and how many minutes do I have left, or how many gigs did I pay for it this month, and when will it run out? Those are real issues. And when we talk about, we saw this increase in behavioral health being done via telehealth. 70% of our encounters were for behavioral health and Medicaid. We heard great things about the fact that people were more engaged. There were fewer no-shows. People were, making better progress. And when we heard all that, we talked to our federal partners and said, it's been a limitation on us in the past because the Office of Civil Rights has told us this isn't HIPAA compliant. They have changed their tune and they've allowed it. And at that moment, it becomes, we got to do audio only because that's what works for a bunch of our members. And it doesn't require them to be hooked up to the internet. It doesn't require them to own a smartphone. It doesn't require them to have a data plan. So in those instances where it's viable and it's a good use of telehealth to do it in that particular way, audio only will be, will continue to be something that we want to do and something that'll be part of the Medicaid program.
Representative Loudenbeck, did you want to weigh in on that? I think you're still muted. Yeah.
Yep. Now I got it. Yes, this is encouraging, and I know my staff is watching in the office because when I think back to all of the back and forth that we did on this to get the language for the bill that we did last session passed, and I was pleased to hear Dr. Schneider say constrained to what it works for. And I think we really struggled with this when we were working with the stakeholders. And so the bill, we're I'm pleased to hear that DHS is proceeding in the manner that they are, that I think COVID has informed that decision-making process and given us a really good look back for the rollout. But specifically in the bill, we excluded audio-only telephone communications, but we specified that the Department of Health Services could specify by rule what communications they are considering reimbursable. And we specifically said that they must consider mental health therapy conducted over audio only. So we tried to give it the best of both worlds, where we weren't saying audio only is not covered. We were saying if we want this bill to pass, we have to open this up in the rulemaking process. And as much as I like to put things exactly like I want them in bills, this was one area that that we agreed to just acknowledge that it should be constrained to where it's appropriate, but understanding that behavioral and mental health were kind of obvious opportunities. And one of the other important things that was in the bill, there used to be a credential required at DHS for behavioral health professionals to provide services to Medicaid clients. So that was like nobody. So there's been, I think, a definite boost in just providers that are willing to do this because of that bill. So that's sort of where it's at with the behavioral health as far as why we made the policy the way that we did.
Thank you. So a current bill going through the legislature right now would include this, the audio only telehealth for behavioral health, but it's a little broader than that. It would include Medicaid to cover and reimburse other things that are already covered. John Nygren, you testified against this bill, saying, quote, "It is not necessarily safe or effective for a service to be delivered via telehealth, especially audio-only telehealth, simply because the service is covered when it is delivered in person." Can you just explain more? Why is this something that insurers are opposed to?
Well, first of all, I would say that it was a little bit more than the amendment was pretty darn broad as far as what it would expand to. And Representative Loudenbeck is a very thoughtful legislator, and she identified how sometimes that we can do too much and put us in a situation that may not be safe and effective for patients throughout Wisconsin. I think that's where we're at as an organization. health plans and providers are still learning what services can be delivered in a clinically effective manner that are high valued when delivered through telehealth. So putting things in the state statute, I think the word constrained is actually appropriate part of this conversation to make sure that, you know, it is high value. And oh, by the way, here's another piece to it too. Telehealth has a great opportunity to expand services that into areas that may not be fulfilled currently right now, but it also provides an opportunity to reduce costs in some areas. So putting things firmly into state statute that make it very difficult for health plans to navigate, I think is where we have some concerns. Government does a great job of providing or of mandating or requiring additional services and treatment, but they don't have a great track record of reducing costs. We still are very concerned about doing both.
So we had, I'm going to get into some kind of more specific audience questions a little later in the panel, but a lot of the questions we received from those that registered was around paying for telehealth as we go forward. So I want to focus a little bit more on that specifically. Representative Loudenbeck, you've been in support of Medicaid covering the same visits for telehealth that they do for in-person health. Do you think that private insurance companies should be required to pay the same for telehealth coverage as they do for in-person?
Like I said, I've asked myself and answered these questions over the past couple of years as we built the framework, and we thought the framework was more important. I served with John Nygren, Representative John Nygren, for multiple sessions. I'm sure, Tim, you remember, but the oral chemotherapy bill. Yep. Which that's been around since my first session in 2011. I remember signing on to that bill. I thought it was the right thing to do. I also think that they had identified the authors, and the bill did eventually pass. But I mean, I've heard cochlear implants. I mean, there's been these mandates that aren't necessarily about the merits of the treatment. But like I said, when I was a new legislator, and then I signed on to it to continue there, because we knew that people that had insurance that could get chemotherapy in person couldn't get the oral chemotherapy. And maybe most of the time they could. Right now, we're not hearing that private insurance isn't covering telehealth. If we start to hear that, then we might need to respond with something. But I don't think that we need to make that decision right now, because no one has identified that it's a problem. So that's where I'm at. So
is it something maybe you as a legislator would reconsider or look into? I mean, in terms of the payment part, right now, there is in certain areas a requirement that it is paid, but as some of these public health emergencies go away, that might become more of a pressing issue. I mean, is that kind of what I'm hearing, that is something you would reconsider, or what are kind of stance on it right now?
Well, like I said, usually as a policy maker, you want to identify a problem and try to and offer solutions. I don't know that this is a problem. And so for that reason, I think that we should allow, I think that Medicaid, I think it was important, because obviously, the legislature needs to, if it's not eligible, then it's not going to get paid, because Medicaid works differently. So that was important to do. And we were mindful that this may be sort of the template, or, what the private sector is going to look to. But like I said, for me right now, if I go back to my office and I have 30 constituents that write me and say they were denied the opportunity to have a healthcare visit with covered by their private insurance that was delivered via telehealth, then I would rethink my stance. But for right now, I am neutral to oppose to putting a mandate on for telehealth at this time. Great.
Jim Castellano. First, I want to comment. It looked like you were sipping out of a Berkey mug. Is that accurate? That's I got the same mug at home. But what do you think about that? Is that something that Marshfield is advocating for? Do you think that it would help if private insurance companies were required to pay for telehealth the same as they were for in-person visits? This is something that other states have done in the last year. Is that something we should consider in Wisconsin?
Absolutely. Yeah. Excuse me. I think parity is essential. Right now, our biggest referral base is our providers, and if providers are getting decreased reimbursement, or if they're getting decrease RVUs due to telehealth visits, it's going to take it right out of the water. Right now, like I said, our biggest advocates for follow-up telehealth visits and initial telehealth visits are our providers, are their biggest source of referrals. If there's not a lucrative, or if they are going to be taking a hit based on that, then that could really impact access and the population that we serve.
Dr. Schneider, what do you think? Do you think it would be helpful if private insurance companies paid for telehealth visits the same as in-person visits?
If the services are equivalent, they should pay. If the services aren't equivalent, I think it's a fair argument that it needs more data to demonstrate, are they equivalent or not? For a lot of the psychotherapies, they are. For things that has an in-person component, you need an in-person component somewhere. I think the challenge is being able to articulate and have it be self-evident to the insurers that it's in their own cost benefit to do this. So the other way to get at this is to ensure they have adequate panels. If they have an adequate panel that they can get everybody seen and they don't have transportation problems for their members, okay, is there really something there that needs to be regulated? I don't think so. But if there clearly isn't a large enough panel and access for the people they're insuring, it makes question.
So, John Nygren, I assume you have some additional thoughts on this one. What do health plans think of this?
Well, I go back to what I said earlier. Look, payment parity. I mean, if there's an opportunity to reduce costs, shouldn't we be talking about that? Locking everything into state statute and make it almost impossible to be able to pass along savings to consumers in Wisconsin is not going to help us provide more affordable healthcare for people down the road. Our members not only expanded telehealth throughout this last 18 months during the pandemic, but they look for other opportunities to provide use technology to provide care that weren't already mandated. One health plan began partnering with a Wisconsin-based company called Grand Care, offering devices to members who are socially isolated with other comorbidities. This is not something that actually is required. It's either not even outlined in their offerings, it's not required by state law, but it actually helps. It actually helps take care of people in social isolation. People that are isolated don't recover as quickly. So doing the right thing from a healthcare outcome is something our members embrace. So in all these conversations, the devil's in the details, and the results over the last 18 months would point to the fact that we don't need these written to state statute.
Great. So I want to shift to some questions from our audience members. These questions were all submitted through the registration process. I just want to thank everyone who submitted questions for doing that. This was probably a record amount of audience questions that we received for today's panel. Fortunately, we don't have time to get through all of them, but we did our best. We hope we did our best to try to pick questions that best represent the sentiment of other questions. And even if your question wasn't asked, we do use these questions to help frame our own questions. So thank you, and please keep sending them. First question is how can we ensure that consumers are given the option to choose telehealth or in-person services and not just steered to telehealth if they don't want to? Jim Castellano, maybe you could take the first crack at this one.
Certainly. During the pandemic, we had a kind of a triage of what we would offer. And the first line of when you call in for an appointment, we would offer phone, we would offer telehealth at home visits, and we would offer the traditional telehealth, and then coming into the clinic would be the last option. So right up front during the appointment process, we kind of steer them and give them options as to how they would like to receive their care.
And we've talked a lot about the promise of telehealth, but what are some of the limitations? And Jim, let's stick with you on this one.
Limitations of telehealth, obviously, connectivity is one. The rural component of that, the connectivity is one. But if and it was alluded to, behavioral health seems to be a very good area that telehealth can offer a lot of services. The in-person touches that are required, then the in-person visit needed. The traditional telehealth, we do have the telepresenting RN with that patient, so they are the hands and the eyes and the ears of that provider. So it's not like it's a complete isolated event where there isn't human interaction, there isn't assessments, there isn't palpations and auscultations. I guess the limitation I would see is if they are needed to have a physical exam in person, then the phone and telehealth at home is not an option. And of course, the connectivity with the rural areas is a limitation.
Thanks. What do you envision as telehealth's biggest impact on the healthcare workforce? Jim Jones, maybe you could take this one. What do you think about that as we solve some access or chip away at some access issues with the use of telehealth? Do we then lessen the demand for areas in the healthcare workforce where we are seeing shortages?
I think we have to be careful. I think we have to remember that this is really based on member choice. Providers have to choose that they want to provide telehealth, and our members have to always have the option of either being seen in person or using telehealth if it's appropriate. We want to make sure that it's evidence-based, data-driven practices that we're moving this forward. When it comes to the workforce, one of the things that we have found and been talking about is this idea, especially in the behavioral health world, where we've cut down on the amount of time that people have to spend going back and forth between different locations where they are providing services. They can stay in one office and see multiple people. So that means that time that they were spending, the 30 minutes between driving from Janesville to Madison or back, that's time that they're now spending with patients or are working on other parts of their medical practice. So we think that's a good thing. We know that we have a shortage of psychiatrists and psychologists. We know we have a shortage of SUD professionals. We think that telehealth can help us in that instance. It will not solve the problem. It will help us a little bit move that forward. We have to remember that we need to make sure we have enough resources in the state of Wisconsin to serve all of our members and the people of Wisconsin with good behavioral health services. But this is just going to be one additional tool in our toolbox to make sure that we're maximizing the resources we do have. We are going to allow some groups of doctors who either are in the state or near the state to provide services as long as they're Medicaid certified in Wisconsin. And we think that'll help as it has in the past a couple of years. So we think that'll help as well. So I think it's good for the workforce. I don't think it's a complete answer. I think we can't rely on it too much, but I think it does help in some instances.
Dr. Schneider, what do you think about that? In addition to your current role, you are the past president of the state's Psychiatric Association. What impact has increased telehealth use had on the workforce?
So first, I think there's a relative misdistribution of access versus where patients are. And I think telehealth will be good at correcting some of that. The challenge, though, is moving too much to telehealth when in fact there continues to be core shortages of professionals only makes that problem worse somewhere else. Or you create the problem that you remote in too many people from far away that don't have an attachment to the close enough community that when they need in-person services, there's no place to get them. So I think being clear that we need to have longer range workforce plans as it relates to how do we support residency, graduate medical education, and or other training and diversity of training to ensure we have a robust workforce. With the aging of Wisconsin over time, particularly into the Jarrow range, that we have adequate services as the population ages. We need all of those things looked at, not just telehealth.
Thank you. And Dr. Schneider, I'm going to stick with you on this next one as well. What are the unique applications and considerations for the use of telemedicine or teleconsultation in the area of behavioral health? So you've kind of touched on this already, but maybe you could expound. I mean, for example, what are like some of the safety issues that need to be considered for specifically telemental health? What happens if, for example, a remote patient is exhibiting suicidal symptoms? I mean, what happens then?
I think there's some evaluations, technical risk-based assessments that may be better in person. I think if we look at DHS 34 that sets the requirements in Chapter 51 that allows emergency detentions by crisis services in the counties to be reviewed via telephone, I think the statutes have already sort of set a telephone assessment to validate emergency detentions. I think it would be great, and other places have already had, where you hand the law enforcement officer goes out with a tablet, and basically they call in the mental health expert on the tablet in the moment of the crisis eval where it's appropriate. So I think there is some gap, particularly in crisis services, where there's probably some focused role for more teleservices than we have. That would get better earlier evals.
So Dr. Schneider, sorry, I'm going to stick with you for one more. This is a separate audience question, but an appropriate follow-up to that. I mean, what do you think about telehealth-only providers for behavioral health services? This is an increasing, there's increasing interest in this space in Wisconsin and across the country. I mean, is this a good thing? What are your thoughts?
It depends on the patient's needs, and it depends on the service provided. So if I have a primary care physician and I have healthcare in my community and I want to have a psychotherapy relationship with somebody remotely, that's probably okay. If I need medication consultation or I'm being treated with medications that have abuse potential or have notable side effect profile, there needs to be some in-person component, even if some of the therapy is provided remotely. And that's where I think sort of parsing these gray areas and sorting out what works. I think one of the areas where maybe we haven't looked enough is there a way to do group treatment, whether they're IOPs or other things like a Zoom meeting, as opposed to having people go to a facility for them, that allow more in-person appointments because other people are doing teleservices to a group at a higher intensity. So I think there's some mixing and matching that we haven't really sorted out what the best ways to do things are yet.
Great. So what more can be done to increase telehealth in long-term care settings like assisted living facilities and nursing homes? Representative Loudenbeck, let's hear from you on this one, but maybe extend it. We've talked about other providers like teledentistry today, and what are lawmakers looking? I know Jim in the Medicaid program is looking at expansion. Maybe we can hear from Jim after this, but what are things that lawmakers are looking at in terms of different settings or different providers in terms of telehealth?
So you brought up teledentistry already, and that's one of the examples that we're hearing. And it's interesting because, again, now we've been doing this for over a year in practice because of COVID, and so we have some of the data, and it's surprising. I can look at the utilization rate on teledentistry is really surprising. But back to the long-term care facility, just the logistics of even let's take away COVID and let's take away rural. Just the logistics of transporting that patient. Long-term care facilities are short-staffed. I mean, if you can send some sort of a clinician, technician, hygienist, whatever you want to call it, to the facility to take some photographs, maybe talk about pain management, and then figure out next steps so that they can maybe save that first visit, even if they have to go in a second time and actually have something in the dentist chair. I think those things make a lot of sense. And I think even for other things, I mean, if you're in a long-term care facility, I mean, you can obviously get some of your basic medical stats from, perhaps from staff that's there, but to just do a check-in or something like that. So there are so many, I think, potential opportunities for just reducing that, like I said, that whole transportation piece, coordinating with the family where maybe, it's easier if the family member could just come in If that's what what the patient wanted. I mean, this whole privacy piece though is really something to consider, because someone shouldn't just be talking on well, I guess they don't even have pay phones, but talking on their phone from their shared living space with their doctor. I mean, or in the sense of, sometimes people feel like they need to have their family there, but maybe they feel like they don't. So like, to make sure that there aren't extra hoops on top of that for the facility to have to navigate, because maybe that's not something they're interested in. But I think there's a lot of potential.
Great. Jim, what are your thoughts on that? I mean, what more
Yeah,
can be done? What more is being done to support this?
Tim, I'm so glad you asked the question about long-term care. Number one, our idea of providing a fee to the originating site, we hope will be a positive in this world for nursing homes and assisted living. But I also don't want to miss out on something. Telehealth and telemedicine includes a lot of the things that people could use to stay in their own homes, to stay where they live, in their apartment, in their home, in an adult family home, in adult daycare, wherever it might be. There's a lot of things in technology, including remote patient monitoring, including a number of other sort of telemetry approaches that we want to start really expressing to our family care MCOs and our IRIS consulting agencies, that really we want them to start exploring these ideas that promote independence, that promote people living in the community and living the lives that they want to live, and keeping that, John mentioned social connection. That's one of the big deals here. Keeping people connected is a huge deal. We've met with multiple individuals with multiple comorbidities and with several disabilities, and they couldn't live in their home without all of the Wi-Fi, internet of things, approach to the way that they can live. From a Ring a doorbell with a camera in it, so they know who's at the door, to opening doors, to being able to talk via their laptop. All those sort of assisted technologies, I think, are a really huge deal to long-term care, and we want to support those, and we want to get them to grow. We want to see them become a bigger part of what's going on. That does relate to cost, but it also relates even more to quality of life, which is what we support.
Excellent. So we have quickly run out of time, but to kind of help sum things up, I want to ask the same question, to give everyone a minute, maybe half a minute to answer one final question. And that is, what is one thing, if you had to pick one thing, what is one more thing that policymakers could do or maybe shouldn't do to support telehealth? And Dr. Schneider, let's start with you.
I think in response to the previous question, some consideration, I think origination fee is a great idea, but also promulgating. So when electronic health care or records were required, there was some federal startup money. If we're going to expect telehealth access at long-term care facilities, should we have some? If a place has so many beds, they need a particular type of hub so that those activities can be done there. And how do we get sort of a technology grant system to have some early adopters to put more wired assistive technology into facility? That might be a very interesting project at the current time to see what works then. That'd be one thought off the top of my head.
Great. John Nygren, what do you think?
Well, Amy Loudenbeck and I have both been around long enough. We've seen a lot of bills come through the legislature that mandate increased, payments, et cetera. But also at the same time, a lot of licensure issues, kind of people protecting their turf. Telehealth is an opportunity for us to, as I said, expand care, right? Expand access, but also reduce costs. So there seems to be two push-pulls going on right here. People that want to expand the access, expand the payment, but also seem to be concerned about how, as we expand telehealth, there might be people coming in from out of state or larger organizations providing this care. If we're truly concerned about the delivery and the cost, we should be open to all these conversations.
Great. Jim Castellano.
I would have to say probably the mandate of the barriers of the MSA, if they could just continue without those barriers would be very helpful. Just because you're in a metropolitan service area doesn't necessarily mean you still have availability or access to those providers, and to be able to reach those providers even if within those service areas via telehealth would be advantageous.
Great. Jim Jones, what is one more thing that policymakers could do to support telehealth?
Yeah, and I'm gonna point my fingers actually at the federal government on this one. I would like the federal government, especially the Medicaid agency, to start equating telehealth and access to the internet to transportation. Medicaid pays for non-emergency medical transportation, the money it takes to get you from point A to point B to see your doctor and back. We think that that telehealth is the same thing. It is a way for you to connect with your provider. At the same time, the federal government believes it's a utility, more like gas and electricity than it is a connective. And for people who are of limited means, who have very strict budgets that they must go by, the idea of having expansive broadband in your home and an internet service is a cost that's actually a step too far for them. So making sure that we provide that kind of access to the people who need it, I think is a big thing that policymakers, both at the federal and the state level, could really support us in doing.
Great. And Representative Loudenbeck, as a state policymaker, what is one more thing? What should be the focus of policymakers in terms of supporting telehealth?
So I think I'm just going to be brief and say it's really about the right care in the right place at the right time. And it's not just telehealth. I authored the community paramedic bill several years ago. I mean, people, whether it's people that are in their home, that are in a school-based setting, for whatever reason, I think, and others have said it, but access and value and opportunity. We need to keep, I think, all of those things in mind without having the unintended consequences. And sometimes those are hard conversations and they involve talking to a lot of people. So I appreciate the panel for getting some different perspectives. I've read all the comments. I know people are really passionate about this and they want to, provide services to their patients, but we just really need to make sure that we put the framework out there. Let's keep the ball moving forward, but understand sometimes we can disagree on exactly how to get there, but right care, right time, right place.
Great. A great note to end on. Well, thank you guys for really a great discussion. Look forward to talking more about this evolving topic. Thanks to all of you for tuning in, and thanks to our generous sponsors for making today's discussion possible.
Thank you, Tim.
Thank you.
Thank you.